To many, the financing and structure of mental health services and substance abuse services makes no sense. And I'd like to be able to say to you that I can make sense out of it. But the fact is that there's probably two fundamental things to understand about the mental health and addiction systems in the United States. One is that it's really not a system. And second is, because they've been so undervalued and underfunded, that commissioners of mental health and commissioners of public health and others have tried to sort of patch together a series of financing structures in order to pay for services rather in a way that isn't really coherent. So what we've done is patch together whatever funding opportunities existed, as opposed to trying to design a system and then figure out what the financing is. So in some ways you could say we've chased money to finance important programs, and that probably is not an unfair statement to make. But it's, and the other reality about the mental health and addiction system is that it has been significantly segregated from medical care and primary care. We'll talk more about that, I am certain. So when you think about a mental health system, for example, the system obviously has a large range of provider categories in it, from social workers, which I'm very proud to be standing in front of you as one. So social workers, nurses, primary care doctors, psychiatrists, so they're specially trained individuals who are able to provide, hopefully, the specialty services that individuals need. On the other hand, anyone could hang a shingle outside of their door and call themselves a therapist. And that helps to confuse what mental health practice is all about. So you could have your degree in economics and literally put a shingle outside your door and say you provide therapy. So that sort of helps to confuse a little bit about what therapists are versus mental health clinicians and the like. The reality is the largest provider of mental health services in the United States happens to be primary care doctors. 73% of all psychiatric medications that are prescribed in the United States are by medical docs and nurse practitioners, and not by psychiatrists, nurse practitioners, and psychologists. So the reality is, while it's a segregated system, most individuals are prescribed their medications by primary care doctors. Some general hospitals have psychiatric inpatient units in them, but many hospitals do not have psychiatric services attached to their general hospitals, and we have what are called freestanding addiction and psychiatric hospitals. For some individuals, McLean Hospital, if you're in Massachusetts, is one of the most prominent examples of a freestanding psychiatric hospital. And the Gosnold Addiction Center on the Cape is an example of a freestanding addictions center. But if you think about it, what would make more sense is that general hospitals, where we go for the treatment of many kinds of medical conditions, would have within their hospital setting psychiatric units. The reality is that many general hospitals have declined to be in the business of providing psych services except through their emergency rooms. The other kinds of provider categories are community mental health centers, which were established as a result of PL 94-163, and community health centers, which some, but not all, also include behavioral health programs. So there's a range of community agencies, from psychosocial rehabilitation clubs to primary care clinics to freestanding psychiatric centers that provide a range and a host of community mental health services to individuals. But the reality is that the system and the financing and the structure of our services is still primarily inpatient and outpatient, and a little bit in the middle called intermediate care services. So how do we finance all of this? Well, it's a bit of a melange, quite honestly. The reality is Medicaid has been the single largest provider and payer for mental health services in the United States and continues to be. About 11.5% of all Medicaid expenditures are spent on behavioral health conditions, and almost 50% of individuals who have Medicaid have a diagnosable mental health or addictions. The commercial insurance So private insurance has been slow to pay for mental health services that we would think of as being important, and has certainly been far behind in the payment for addiction services. It really wasn't until 2008 and the passage of the Domenici-Wellstone law that for the first time federally there was a requirement that commercial insurers, certain commercial insurers, need to improve their payment for behavioral health conditions. The other is we start to talk about how to understand what behavioral health and health expenditures by payers have looked like. It's one of those sobering realities that the number one reason why individuals file bankruptcy in the United States is for medical reasons, and it's well understood that the number one reason within medical bankruptcy is for behavioral health. So the private insurance has been slow to sort of increase what we would know as parity. But the next couple of slides give you a really good depiction of the disparity of financing for behavioral health and all health services. And there's a couple that particularly stand out in terms of government and private payers. So if you look at sort of the out-of-pocket, so what you pay for out of your pocket in terms of pay for a service by yourself, pay for co-insurance or a copay. For behavioral health, it's about 11% comes out of pocket, as opposed to 13% of out of pocket for all health services. But more important, look at private insurance. Private insurance for all health services pays for about 37% of health care, and for behavioral health, it's a quarter. And then when you look at Medicaid, Medicaid becomes a much more significant payer of behavioral health services than for the rest of health care. That gives you a good sense that the public payers have been a much bigger provider than for primary medical services. But the next one is even more illustrative of this disparity of health care expenditures. Because if mental health has been the stepchild of the healthcare system, substance abuse has been the stepchild of that system in terms of expenditures. So this chart will show you mental health as compared to substance abuse. So there's a couple of things that really stick out here. And this is 2005 data. So we would expect over time, with the impact of the Affordable Care Act, that these numbers should shift, hopefully in the right direction. The out-of-pocket expenditures for both substance abuse and mental health conditions tend to be higher than for medical care. But when you look at private insurance pays for only about 12% of addictions care in the United States. And we know that addictions affects about 13 million individuals a year. Also, the amount of money that is spent on where it says other state and local, you know what those are? That's like block grants. That's like State Department of Public Health dollars paying for the treatment of a person with addictions. The disparity in terms of what is paid for by public dollars versus commercial insurance is just so profound when you think about the payment of services for someone with an addictions and for mental health as compared to physical health. These two charts really give you a very good sense of how, as a country, how we valued mental health and addictions, and clearly we have not valued them well in terms of the financing, except by government. Government has stepped up when no one else has, and we all know in government there's never enough resources to meet the need. This just gives you a little bit of a sense of the differing estimates of who pays for mental health services. The reason this is important is just, again, it does show you the differences between private insurance and the government payers, but also it's been difficult to really estimate who is paying for care. You would think that it would be easy to figure out who's actually paying for care, but as this sort of points out, whether it's the Medical Expenditure Panel Survey or SAMHSA's spending estimate, it's sort of all over the place in terms of how we define. These charts actually are pretty different because of how we define what the mental health services are. and how we catalog, if you would, who's paying for what. And this is the last chart on this section that I want to talk about, because it really shows you the differences of what we pay for and what kinds of services people are getting. You see the huge role of pharma now in a period of almost 20 years of the primary treatment for addictions and mental disorders has become prescription drugs, and that the role of inpatient has reduced significantly. And the takeaway from this chart is that we have moved mental health and addiction treatment from primarily hospital-based to community-based care, and in so doing, we have shifted the acuity of patients from inpatient services to outpatient. That has a significant impact on provider capability to meet the needs of individuals with behavioral health conditions.